My name is Erin O'Malley, and I'm the Program and Outreach Coordinator at Northwestern Medicine Living Well Cancer Resources. I'm so happy to welcome you all to tonight's special medical presentation featuring our own Laura Waldoch, who is a nurse practitioner at Northwestern Medicine Delnor and Kishwaukee Hospital. This is a reminder, too, that if you have any questions throughout this presentation, to just drop them in the chat, and then we will get to them at another time. And we just really appreciate you all joining us virtually tonight. And I am going to now pass this on to Laura.
Perfect. Thanks, Erin. As Erin said, my name's Laura Waldoch. I'm a palliative care nurse practitioner at Delnor. I also cover Kishwaukee Hospital when I take call for our team. I have my doctorate in nursing, and my doctoral project involved palliative care for patients with advanced cancer. I've been a palliative care nurse practitioner since 2019, and prior to that, I was actually an oncology nurse practitioner. So thank you so much for joining tonight and to learn more about palliative care. I know it's cold and yucky out, so I'm glad we're inside. So why would an oncologist refer a patient to palliative care? So palliative care is often wrongly, we get a bad name. We're often wrongly confused with hospice or end-of-life care. But when your oncologist tells you that they're referring you to palliative care, it can sound scary at first. Another name for our team, I think actually a pretty good name, would be a supportive care team. So we are the ones responsible for managing symptoms of both the disease itself and the treatments. Sometimes there are side effects or symptoms from the treatments that we help manage. We are what we call the quality of life team. Our goal is to improve your quality of life while you're undergoing treatments for your cancer. We are what we would call a multidisciplinary team. We are under the oncology umbrella. We are the people who look at the whole person. The physical side, the spiritual side, psychosocial, where everybody is more than a disease. So we try to see how everything is working together. You may notice I may say palliative care, I may say palliative medicine. We can use those interchangeably. We're called both of them. At some institutions, mainly on the west coast of the country, they do call palliative care the supportive care team. Palliative care is just like any other specialty. We are our own specialty. We are covered by insurance, just as a cardiologist or oncologist would be covered. We're covered by Medicare, Medicaid, and private insurance. So who can qualify for a palliative care consult? So it's a relatively younger specialty, as I'll talk about in a few minutes. And we started with oncology patients, but we actually see all patients, any patients who have a late or end stage chronic, life-threatening, progressive disease. Examples would be advanced cancers, end-stage cardiac disease, more towards the end of a CHF, a congestive heart failure journey, or a patient with, say, like a severe aortic stenosis that would not be a candidate for further treatment. We see lung diseases, interstitial lung diseases, COPD, end-stage neurological diseases like Parkinson's, when they're more advanced, dementia. We've had patients with ALS. Infection, we're skipping down to that one for a sec. Sometimes we see patients who have chronic infections that are resistant to antibiotics. GI disease, which is gastrointestinal diseases such as liver failure, and genitourinary diseases like patients who have kidney failure. So I really want to talk about, a lot of people don't understand the differences between palliative care and hospice. So there are definitely some similarities, but there's very important differences. So patients can be under either palliative care or hospice care if they are diagnosed with a life-threatening progressive disease that will ultimately take their lives. So both palliative care and hospice teams care for patients of any age, including children. Both palliative and hospice teams have the goal to alleviate or lessen any symptoms of that disease in order to improve the patient's quality of life. Both palliative and hospice teams have a multidisciplinary team that includes providers such as physicians and nurse practitioners, nurses, a social worker or counselor, and a chaplain. but that is pretty much where the similarities stop and the differences start. Some hospices team may have additional services like respiratory therapy, physical therapy. I know there's one that offers massages, there's pet therapy, music therapy. We don't have those. But the biggest difference is that patients who are engaged with us in the palliative care team, they continue to undergo treatments for their diseases. So the patients who enroll in hospice are no longer undergoing treatments for those diseases. And they're focusing on comfort. So with palliative care, it's under the traditional medical system where the patient goes to the medicine, they go to the hospital, they go to the clinic, to the doctor's office, the labs. And with patients under hospice care, the medical care goes to them. When we get our certifications for hospice and palliative care and hospice, so when I have my certification in that, when our physicians do their fellowships, it is palliative and hospice, but they are two very distinct specialties. If somebody says to you, your oncologist says to you, hey, I think we should get palliative care involved, they just want to improve your quality of life. We're not hospice. Hospice itself, though, is a Medicare benefit, and it's also offered by most private insurance companies. Just a quick little plot twist. So hospice agencies typically have, Northwestern doesn't own a hospice agency. Okay, we don't do hospice for the most part. So what we do is we engage with these community individual hospice companies. Hospice companies typically have also a palliative arm to them. That's set up a little differently than us. We also call it community palliative. It's when a nurse practitioner goes into the patient's home, wherever the patient is. It's typically once a month. And they don't prescribe medications directly for the most part. There are some agencies that do, but they work with the primary care physician to address the symptom management. They don't have social workers or any of the other access that our palliative care team has, or like hospice has, all the interdisciplinary team. But they do go into the home. So patients who are homebound or patients who live in nursing homes or facilities, that's usually a pretty good option for them. So I do like research, but this is actually, I would call this the seminal study that showed how effective palliative care was. This was a study in 2010 by Dr. Jennifer Temmel, who's a lung oncologist at Mass General and Harvard in Boston. And she took 151 newly diagnosed patients with advanced non-small cell lung cancer. So just a quick little caveat. In 2010, that was a fairly grim prognosis to be diagnosed with that. I would say that at this point, we have come so far with these targeted therapies, it's a much different scene. But anyways, when Dr. Temmel did this study, she took 151 of those newly diagnosed patients with advanced lung cancer. She split them as evenly as you can split 151 people. And so in the control group were, 75 or whatever patients that had standard of care treatment for that cancer. And in the intervention group was those 75 or 76 patients had the same exact treatments as the control group, but they also engaged with palliative care early on in their cancer journey. Okay, so they measured mood and patients' perception of quality of life at baseline and then after 12 weeks. And patients in the palliative care arm reported a better quality of life than those under standard of care, under just the standard of care, the control group. In addition, for depression, 38% in the non-palliative care group reported depression. And for the patients under palliative care, 16% of those reported depression. But most notably, however, was that the median survival was longer among those who received early palliative care, and nearly 3 months longer. So that's a very significant statistical finding. And so the results were longer life with improved quality of life for those patients who engaged in quality palliative care early on. in their cancer journey. And so this study has been replicated multiple times, and it gives credence to the field of palliative care. I like this. I like this image a lot. So this is from something called Mayo Clinic Proceedings. This shows the evolution of palliative care and how it can be utilized most effectively for patient care. So in the top bar, this is how it used to be when palliative care was just starting, or even before palliative care. It was disease-directed care, and most of just until the end of life, basically. Most of those patients died in the hospital. Okay, they would typically die in the hospital. In the bottom bar, it's a very good depiction how cancer treatments can coexist with the palliative care team to improve quality of life. And there's a larger chunk of time the patients have at the end of life to be with family and friends. I like this because it shows how palliative care works with cancer treatments and not against them. Okay, so there is very robust evidence that patients with advanced cancer benefit from palliative care. The NCCN, which is the National Comprehensive Cancer Network, the American Society of Clinical Oncology, internationally, the WHO, they all recommend timely palliative care for patients with advanced cancer. Palliative medicine, what we look like, what's Northwestern's model for palliative medicine? So we are used as an inpatient consulting team and as an outpatient clinic team. So each provider, physicians and nurse practitioners, between Delnor and Kishwaukee, we have 3 nurse practitioners and 2 physicians, and we just hired 2 additional nurse practitioners as well, 1 for each site. We each have our own clinic day where we see patients at the cancer center. When it's not our clinic day, we're in the hospital rounding on patients. Yesterday was my clinic day. I was over at Delnor Cancer Center all day seeing my patients. Today I was at the hospital. We have a provider on call, just like any other specialty, 24 hours a day, 7 days, I mean, more than that, 7 days a week, 365 days a year. And once again, we're interdisciplinary. We are very, very collaborative with each other. Every morning we meet and we have what we call a huddle. And so it's the chaplain, the social worker, any providers that are there that day, physician, nurse practitioner, the nurse, and we talk about our patients. We talk about our patients inpatient. We review our patients that we're going to see outpatient, just to get ideas from other people. So these are some of the symptoms that we treat. So when patients' symptoms are managed, their quality of life improves. So since we're the quality of life people, symptom management is very high on our list, and it's a critical part of providing what I would say would be really good palliative care. We love collaborating with our oncology partners for good symptom management. Specifically, we are the experts in cancer-related pain, and patients are often referred to us initially. We meet them to help manage their pain. We also help to manage things like decrease in appetite, nausea, bowel issues, breathing issues, sleep, fatigue, mood issues. The presence of any of these can negatively impact quality of life, and that's what we are always hyper-focused on, is quality of life. It's really hard for me not to use my hands, trying hard. Symptom management-wise, if you can scoot on to the next slide, please. Thank you. I want to speak really specifically tonight too about cancer pain control. Managing cancer pain can also help to improve any other symptoms that patients are having. If you're in pain, it's hard to sleep. You don't want to eat. Your mood can be poor. Pain can make you very, very fatigued. So we need to address pain. Pain is an unfortunate but common symptom for patients with cancer, and it is actually one of the most feared symptoms by patients who are diagnosed with cancer too. There have been surveys done, and pain is right up at the top. So if you look at the total cancer population, patients from stage 1 to stage 4, about 66% of those patients experience some type of pain at some point. And for patients with advanced cancer, we're looking at a number of probably 80% moderate to severe pain at some points. Cancer, that's okay. Cancer pain is strongly linked to a patient's quality of life, so that's why it's important when we treat it. As an aside, just I'm throwing it out there and doing a little teaching too. If you are on pain medication, it's really important to stick to that pain management regimen that we have you on. Once control of pain is lost, if any of you have had surgery before, you know, once you lose control of that pain, it's much harder to get on top of it. So I would just encourage anybody who's on a pain management plan to be very compliant with it. So incidence of cancer pain, you know, cancer-related pain is actually more common for younger people than older people. We don't entirely understand that. We don't know if older people generally experience less pain or if they classify pain differently because they might have had more experiences with pain along their life too. They also may report it less. I mean, it could be a generational thing. Is it due to stoicism, memory loss, confusion, or fear of being a burden? There's people who are just not complainers. Patients with advanced cancers, like I said before, do tend to experience more of the pain. Also, the type of cancer and the location of the cancer can change that risk of pain. Also, the types of treatments, the types of therapies that we're doing can also increase or decrease the risk of cancer associated pain. So causes of cancer pain, it could be the tumor itself. Is it taking up space, pressing on an organ or nerves? You know, when we look at pictures of the human body or drawings of the inside of the body, it seems very neat, and here's the heart, and here's the liver, and here's... when you actually see inside a human body, everything is just smashed together like that. And so when there's an area that's larger than it's supposed to be, it can stretch other parts. It presses on other parts of the body. And so you can feel pain, even if it's, let's say, in your liver, you can feel it in your shoulder. I mean, there's referred pain too. Is it cancer treatments that are causing the pain? We do that sometimes, you know, surgical pain. Did you have surgery? This will be present after you have surgery. There'll be pain. But sometimes even after recovery, that post-surgical pain can persist. Chemotherapy or immunotherapy, they can both cause like generalized aching, especially chemotherapy can cause, you know, that deep aching, muscle and joint soreness, abdominal pain and cramping, even a headache. Excuse me, a headache. Depends on what type of chemo you have and the location of the cancer. I'm sorry. Immunotherapy can cause what I call the itises, which is an inflammation. And so, for example, excuse me, a colitis, which would be an inflammation of the colon. So this can cause abdominal cramping. Sometimes people can get a pneumonitis, which is like an inflammation of the lining of the lungs. This can cause pain from coughing or using those muscles to breathe extra hard. Radiation, which is a treatment, can lead to pain. You can have like a sunburn on your skin. I'm sorry. The radiation oncology team is excellent in managing this. They have great creams to tell you about, topical ointments. Radiation can also cause like a pain flare. It can really tick off the cancer that we're trying to radiate it, and it causes an inflammation inside the body. This can be frustrating for patients, especially if they're undergoing radiation for pain management and all of a sudden their pain temporarily increases. Some patients receive a class of medication called bisphosphonates, and so especially if there's cancer in the bone, we give this IV medication to make your bone stronger. And sometimes after that infusion, you can feel achy after that. I think I'm the next one. Yeah. We recognize there are different types of pain, and physical pain can be impacted by social pain, spiritual pain, psychological pain. So as a multidisciplinary team, we have the abilities to address all those types of pain. We have the chaplain, we have our social worker. So this is pain is complex, and one type of pain affects the other type of pain. So we will really drill down to see exactly what type of pain there is, what's the cause of it. is the WHO ladder for pain management. This is what we all tend to follow in the whole medical world. So we're generally going to start by following, we call it the motto, by the clock, by the mouth, and by the ladder. So this means take pain medications regularly. We kind of talked about that already. We always want to try the mouth over IV. And then we always want to follow this ladder. We're not going to start with the strongest opioids for your pain. So this is the safest way to treat pain right here, this little ladder. So the first step for mild pain, we usually use non-opioid pain medications with or without another medication. I like Tylenol. Now, there's people, don't hear me out on this too. Tylenol is, there's something called Tylenol arthritis that I am using for some of my patients with cancer-related pain, and it's very effective. I have them just take it 2 tabs twice a day. Of course, always check with your oncologist first about pain, okay? So then if we have some moderate pain, we may look for a mild opioid, a very small dose opioid, but you keep that Tylenol on there. You keep that base pain medication on there. And then the third step is for pretty severe pain, and we'll be more aggressive with the opioids. So we can go up and down this ladder. You can be diagnosed with cancer and have a lot of pain, and so we can rapidly escalate that to the top step. But then once you start chemotherapy, you start feeling better, and we go back down again. Our plan is never to get anybody addicted. Okay, so multimodal pain management, it's kind of like what I already talked about. We'll use Tylenol plus something else. We talk to our patients for a long time when we first meet them to try to figure out what the best pain plan is. It's what type of pain you're having. Where is it? What is it coming from? We ask you for descriptors. Is it burning? Is it aching? Is it stabbing? So a good assessment of pain will help us formulate the most appropriate type of pain control. Once again, I'm going to get back on that Tylenol. Be sure to always talk to your doctor and see if they want you on it. But that Tylenol arthritis has been very, very effective. We also have the NSAIDs. We typically don't use those for patients with cancer. I'm talking about like ibuprofen, Advil, Aleve. We use those pretty cautiously. They're over the counter. That doesn't mean they're innocuous. They can be hard on your stomach, damage the lining of your stomach, your esophagus. If you're undergoing chemotherapy and it reduces your platelet count, these medications can reduce your platelet count as well. They can affect your kidneys. They can affect your heart. So be very, very cautious with these and always talk to your oncologist before you take these. If somebody tells me they have burning or shooting pain, to me, that means it's probably what we call a neuropathic pain. There's nerves being affected. And there are medications we can use for that called gabapentin or Lyrica or duloxetine. So it doesn't always have to be an opioid to treat the pain. Actually, some studies have shown that for neuropathic pain caused by chemotherapy, which is that numbness, tingling, shooting pains, a menthol-based cream can work, at least for short periods of time. We always try to look at something that's not necessarily another pill. I have actually recommended patients for acupuncture and massage for their neuropathies, and it's been effective. Not everyone, but some of them are effective. If we can find a dual purpose for a medication, and we only have to give one pill for 2 different symptoms, that's great. Like that medication duloxetine is actually a mood medication, but it has been shown to help with chemotherapy-induced neuropathies. For a brief period of time, if the pain is due to inflammation, but steroids do have their own set of serious side effects as well. And so we typically don't use them if the patient is undergoing immunotherapy, because it kind of reverses what the immunotherapy is trying to do. The immunotherapy is trying to rev up your immune system, and the steroid is trying to slow down your immune system. So they are very effective for sometimes if somebody has bone pain or liver pain, but we always will collaborate with the oncologist for that particular drug to make sure that it's not going to interfere with the treatment. I don't know if any of your oncologists have told you to use Claritin. for a special type of pain. So sometimes when patients undergo chemotherapy, chemotherapy can kill blood cells, and we will help. We can give shots to help your body, force your body to create new white blood cells, and sometimes that can cause like deep aching inside the bones because it's forcing inside your marrow to make more white blood cells. And sometimes Claritin, just over-the-counter Claritin, can help with that type of pain. They think it's some sort of maybe histamine reaction, and then the Claritin just calms that down. So, and then opioids. Opioids are probably what we most use for patients with cancer-related pain. But we are always going up and down on the doses, and that's who they were created for. We have a lot of patients who are afraid they tell me I don't want to become addicted, and they were created. They're not created for the kid who gets his wisdom teeth out. They're created for the patient with cancer. So there are some myths associated with cancer pain. So I'd like to briefly address a few of them. Everyone with cancer experiences pain. That is false. I would say a lot of times if the cancer is located in certain areas, you don't feel any pain at all. And it depends on the stage of the cancer as well. A lot of times those with earlier stage cancer, they're surprised they have that cancer diagnosis even because they're not experiencing symptoms. So pain is just a physical issue. False. We talked about that. There can be emotional pain, which can complicate physical pain. There's all different types of pain. Anxiety, stress, depression, they all complicate that physical pain. Cancer pain can only be treated with morphine or strong opioids. No. We can do other things too. Ultimately, we may need those, but there are other ways to treat. If my pain gets worse, it means my cancer is getting worse? No, not necessarily. There's different reasons that people develop pain. If I use opioids, I will be a drug addict. I get this a lot. People would sometimes rather suffer. But we have a good conversation that addiction is something when the medications are not prescribed for you, or when you will cheat, you will lie, you will steal for the drug. The drugs are being used inappropriately. We're all very all of us providers in palliative care, we're very diligent about keeping our eye on patients. No. As far as I know, I've prescribed hundreds and hundreds of different patients opioids, and nobody's become an addict so far. Palliative care means you are no longer undergoing cancer treatments. Absolutely false. There are even people at the hospital who believe this, but absolutely false. I've had patients in my clinic since 2019 when I first moved over to palliative care. Goals of care conversations. Okay, the elephant. Why do I have an elephant in there? A patient once told us, oh, wait, so you're the people who talk about the elephant in the room. And they're right, that we are the people who do that. So we've kind of adopted the elephant as our team mascots. In our office, we all have little elephants everywhere. So goals of care conversations are really a piece of what we do. So I just want to explain what this means. I think my patients, I think they don't even know that that's what we're doing because we're just having conversations. Goals of care conversations are simply conversations that we have with patients during our visits that help us to learn the patient's wishes and their worries. They're conversational, they're exploratory, they're longitudinal, and we're really, really good at them. There's certain ways to have conversations that we've been trained to have them that way. They can take a chunk of time. We're very fortunate that we're the team that we have all this, we do have this time built into our schedules. So like my follow-up clinic appointments, they're 45 minutes long each, which is unheard of in modern day medicine. Our new consult time periods in outpatient are 1 hour long. So we have the time to sit down and get to know people. Because how do we know your wishes and your worries without sitting down and getting to know who you are? I cannot just walk into a room and say, what do you wish for? What do you worry about? I walk in a room and say, how long have you been married? Where were you born? My big question is Cubs fan or Sox fan? So, we get to really know our patients. Like I said, I have many patients that I've seen for years. They know I have 6 kids. I know where their grandchildren go to college. Our conversations build trust with each other along the way, and sometimes even friendships over the years. So it is important to establish with a palliative care team as early as possible, actually, so we can support better, so we can make sure that we always understand what that patient wants. I always encourage my patients to advocate for themselves, always. And I always tell them that I will be their advocate too. When we have an outpatient that is admitted to the hospital, we see those patients for continuity of care. I think that they're always really happy to see a face that they know when they're admitted to the hospital then. So it's like I said, it's important to establish early on with us so we're recognized as a member of the care team and the patients are comfortable with us. When we understand your goals, we can work with the rest of the medical team to make sure that all the interventions that we're doing are with your goals in mind. The medical world can be like a snowball going down the hill. And pretty soon, you're in that snowball and all you can see are your fingers and toes. And it almost feels like you have no control. You get this diagnosis and it's like, well, now you have to go to the lab here, go to the doctor here, go do this test here. And it's a real loss of control. And we really work hard to try to make sure that you understand that, yes, you do have control. You should be the most important person in that room all the time. So there are medical goals and there are personal goals. So medical goals, I have patients, telling me, I want to do another round of chemo, or I want to keep doing this until you can't see any cancer on the scans. There's personal goals. We talk about those a lot, and we really work hard to get our patients to meet those goals. Go to my granddaughter's wedding, see my son graduate from high school. So studies have shown, and I told you I like research, I like studies. Studies have shown that goals of care discussions are linked to reductions in hospitalizations and emergency room visits and decreased family conflict. So once again, the earlier, the better. It also makes us less scary when patients meet us early on in their disease process. It helps normalize our presence on the care team. We always want to make sure your voices are heard, okay? And one of the ways we can do that is with, we help patients figure out their advance directives. So right now I'll talk about healthcare power of attorney. This is not a document that you necessarily need to do with an attorney, not at all. The social workers at the cancer center can help with it. You are naming a person who you want to make healthcare decisions for you if you can no longer make them yourselves, okay? This doesn't necessarily have to be a spouse. It doesn't necessarily have to be a family member even. It needs to be somebody who you think will follow through with your wishes. I'll give you a personal example. I've been married 38 years. I love my husband. He loves me. I know he does. I'm afraid he loves me too much. I'm afraid he'll leave me on a ventilator in a nursing home or something. I just don't know if he will have the ability to make a decision that I would want. And so my son, who's a surgeon, is my healthcare power of attorney. He may let me go a little too quick, but they can work together. So it's really important that you have trust in that person will follow your wishes, because it's not following their wishes, it's following your wishes. This does not require a lawyer. Only a witness, cannot be a physician or a nurse practitioner or a nurse, but the social workers can help with that. And this is only for medical decisions. People will start talking about their finances. I'm like, that's something completely different. That is done with an attorney. Recommendations are that you have 2 separate people for the financial power of attorney and the medical power of attorney. And once again, I'm going to say the most important part of this is talking to that person, telling them what you want. They are your voice. And like I said, I love advocating for my patients. And so I tell my patients all the time, have you had that conversation with them? Tell them what you want. They're not, Thanksgiving table conversations, and they're hard to have, but it's really important. I am a very firm believer that anybody 18 or over should have one of these. If there is no healthcare power of attorney form on file, then there's something called the Illinois Surrogacy Act. And so it's a whole list of who it would be going down in order. So for example, if you're married, you don't have a healthcare power of attorney form in the state of Illinois that is your husband, or your spouse, your partner, your spouse. It has to be a legal marriage. If there is no spouse, then it goes down to adult children. If there's no adult children, it goes down to your parents. I mean, so it's a whole process all the way down. Recommendation is get that on paper and then talk to the person who's the healthcare power of attorney. So this is another way to make your voice known. It's a PULST form. It's a provider order for life-saving treatment. This is a medical order. It can be signed by a physician, a nurse practitioner, or a PA, physician's assistant. The goal of it is to honor a patient's wishes and set any limitations on care or specific care wishes. This is what people call the DNR form, okay? So this form at the top is simply asking the question, if your heart stops, if you stop breathing, and the definition of that is somebody has died, do you want us to try to bring you back to life? Do you want CPR? Yes, no. There's other questions on there that get more detailed, but those are all optional. You can fill this form out and say, yes, I want that. That's fine. It's not just for a do not resuscitate. It's also for a full code, a full resuscitation. This is a state of Illinois document as well. You can find it at that site that's down there, pulsedillinois.org. It needs to be signed by your physician, your nurse practitioner, your PA. It is your voice, once again. And we always say in palliative care, we walk beside our patients. I want to make sure that you're fully informed of all your choices, fully educated, because that's when you can make the best decisions. And then we walk beside you. We don't tell you what to do. Okay? Just making sure you have all the information. You want to check the full code on there and be a full code? That's fine. I don't walk in your shoes. But we hear your voice then, and that's what the important part is. Sometimes people say it's an orange form, it's a pink form. To be honest, that's old. That's when we used to keep them in paper charts before computer charting. So this form, it doesn't have to be any color. White is fine. It can be updated, revoked anytime. You can do one every week if you want. It doesn't make a difference. We can scan it into your medical record so nobody asks you about it. This is, if you're in the hospital and you say, I want to be a do not resuscitate, that does not carry when you're outside the hospital. This form carries through when you're outside the hospital. Why is there a refrigerator on there? In the state of Illinois, the paramedics, when they come to the house, know to ask for something around the refrigerator. They've decided that a refrigerator is something that most people have in the house, even more so than a TV. So a lot of people keep those forms in an envelope, in the refrigerator, on the refrigerator. The paramedics will say, do you have any forms around the refrigerator for me? So that's why there's a refrigerator on there. Okay, so I found this a couple of years ago, and I really like this because it summarizes how our team looks at illnesses. We really try hard to look at the patient before the illness. So, sometimes we'll see in notes. She didn't fail 6 rounds of chemotherapy. Chemo failed her. She wasn't the failure. The chemo failed. She didn't progress. The disease progressed. She never complained about the side effects. She reported the side effects, just like we told her to. Nobody's complaining when they call and tell us they have pain. We told them to call and tell us they have pain. She didn't become palliative. She needed a new way of treating her whole being as she lived.